Okay, welcome everyone. Thanks for joining us today for the webinar on what to expect before, during, and after the Zephyr valve procedure. We have some great panelists today who are joining us, and I'm just going to talk through a few administrative things at the beginning of our slides and then hand it over to them. You can tab through, that would be great. Excellent. So this is the fourth webinar in a series we've been doing about Zephyr valves and the questions patients have and the guide to testing and understanding valves. And today we're really focused on what a patient who's going for the procedure can expect before, during, and after. So we're going to dive deep into this one today. But the previous webinars are also available on our website all the time. You can go on and watch them at your convenience. So that's the link down there if you want to find some of those previous ones we have done. And we'll share that again at the end of the webinar as well. So you may have some questions come up in your mind as we walk through some of this. And we're going to have some time at the end to ask those questions live to our presenters today. So at the bottom of your screen, you will see a Q&A box. And if you click on that, that will allow you to submit your questions so that we can address that at the end of the presentation and have that answered live for you. And sometimes we do get, hundreds of folks online and a lot of questions come through. If we don't get to your question, we will follow up with you within the next day or so with an answer by email. So we appreciate you attending and putting your questions forward. We'll also send you a follow-up email after the webinar today. So if you came on late or you have to leave early, we will let you know what was covered, and we'll also send you the link so you can watch the recorded version. So with a great honor, I introduce you to our speakers today. We have Rebecca Preeb and Jill Bunn with us, and they are two of our rock star folks who run a Zephyr valve program and work with patients every day who are going through the Zephyr valve procedures. So they're going to walk through the steps and what this really looks like for patients and share their firsthand experience on what the patients that they work with have gone through. So I will hand it over to them and we'll dive in.
Again, I'm Rebecca. I'm a nurse practitioner. I run the lung volume reduction program with valves in Detroit. And we'll talk you through some of the slides. We're happy to answer any of your questions toward the end. This is our agenda. We'll go over kind of an overview, talk about some pre-procedure preparation, the day of procedure, with some pictures during the procedure, after the procedure, and then we'll try to have enough time to answer most of your questions. So what are the Zephyr valves? So they're tiny one-way valves, or a check valve for those engineers out there, but it's a minimally invasive procedure. So these valves get put into a tiny scope. There's no cutting or stitches or incisions or anything. And we place them going through your mouth or nose. It treats patients with COPD that has specifically emphysema. And so when we talk about emphysema or COPD, what does that mean? Because there's hundreds of thousands of people with COPD in the United States. COPD is really the umbrella for lung disease. It would be like the street name of your wherever your house sits. But COPD is made up of categories. One is bronchitis, people who have a lot of secretions in the morning and all day. And then people with emphysema, people who are plagued by gas trapping that cause emphysema and shortness of breath. So if we look at this slide, normal tissue is very elastic and it has these tight, it looks nice and tight and healthy here, and a large surface area. People are able to breathe easier. The lung expands and contracts normally. The diaphragm, the muscle that helps you breathe, can move up and down nice and freely. But when people have damage to their lung parenchyma, they can trap gas inside their parenchyma, and it destroys the tissue. This destruction is irreversible. And so you start to get these large holes within the parenchyma of the lung. And as you take breaths in and out, about 2/3 of that air can come out, but there's still about 1/3 or a little more that can get trapped inside there. And over time, as you trap more and more gas, the lungs become large and long, and it puts a lot of pressure on the diaphragm, which is the essential muscle that helps you breathe. When you have a lot of pressure on your diaphragm, it flattens out. And when it flattens out, it can't move nice and freely. And so that's really the mechanism of why you're short of breath. Over time, you become more breathless and breathless the more you exert yourself. And patients with emphysema who have this severe hyperinflation or long and large lungs also complain of, trouble bending over, tightness around their chest and abdominal region, feeling full when they eat, or having acid reflux type symptoms because of it. We know with the disease progression with this gas trapping, we get this stage of disease where you get these long lungs, you become short of breath, then you become less active because you're too short of breath when you walk or grocery shop or shower. And then you have this reduced exercise capacity. So you become more breathless because now you're fatigued and debilitated from not exercising. You further decrease your activity because, again, it's getting harder and harder, or maybe now you're using oxygen, and then you get further deconditioning. That can eventually lead to a higher mortality the less active you are. This procedure is for that shortness of breath. It's to help eliminate those feelings of breathlessness so that you can remain active and, live a long, prosperous life doing the activities that you want to do. The Zephyr valves have been proven safe here in the United States, but the FDA approved it here for this valve in 2018. We've treated over 25,000 patients globally, and it's now part of the gold standards for care for patients with COPD. And it's one of the recommendations before talking about big surgical interventions like lung transplant.
And so there's a lot that goes into seeing if you're a good candidate for the valves. There is a lot of pre-procedure testing, and we're going to go through some of that just briefly. So you have to have a confirmed diagnosis of emphysema and COPD. That's number one. You have to not be smoking for a minimum of 4 months, or those requirements might be a little bit different at other facilities, but at ours, it's 4 months minimum of no smoking. You have to find a Zephyr valve treating physician who, not all pulmonologists do it, and not all pulmonologists even know about the Zephyr valve. So be your own advocate and, look for a treating doctor somewhere close to you. And really only a doctor that does the Zephyr valves can really determine if you are a good candidate or not. Like I said, a lot of regular pulmonologists do not even know what the qualifications are or who these valves really do help. So, definitely be your own advocate and, search out a Zephyr valve treating physician in your area. So the main thing that we're looking for is, on your pulmonary function testing. So there's a couple things that we really look for to see if you are trapping enough gas in your lung tissue that these valves will really help you. You have to be trapping the gas or else the valves are not going to do anything for you. So different facilities have different parameters for those numbers, but that is the main thing, is you have to be trapping gas. The second thing is a 6-minute walk. The 6-minute walk is really to see if you're healthy enough to undergo surgery, and you really just need to be able to walk at our facilities 100 meters or 328 feet, and that's in 6 minutes, and that's with whatever oxygen you're already on. And we just want to make sure that you are mobile enough and can, get around and stuff. So the third thing is the arterial blood gas. That's just to make sure and test how much blood, how much oxygen and carbon dioxide are in your blood. Because some people hold on to a lot of carbon dioxide, and if that's the case, then we have to explore how to expel some of that before we can do valves. An echocardiogram is really important before you are a valve candidate. We have to see if your shortness of breath is actually coming from your emphysema or if it's coming because of your heart. So it's really important to make sure that your heart is pumping adequately enough and that you don't have pulmonary hypertension, which is one of the things that can really cause that shortness of breath. CAT scan. We do a CAT scan that we not only are looking for how much emphysema you have, we also are looking for any lung nodules, any suspicious masses. And then just make sure that there's nothing concerning before we would go forward with valve placement. Once we have that CAT scan done, we put it through a special system. It's called the StratX, and we get the StratX report back. The StratX report really tells us if you are going to be a good candidate or not. It's going to tell us how bad your emphysema is in all of the lobes of your lungs. And it really does look at both your right and left lung. And some people don't know you have 5 lobes of lung, 3 in the right and 2 in the left. So it really tells us which ones are the most damaged and where the valves would benefit you the most. And then a perfusion scan. We don't do perfusion scans on everyone. It's just to see which lobe of your lung is the laziest. If you have a lot of damage throughout the lobes, all of your lobes of lung, we want to determine which one is the best to put valves in. And that would be with a perfusion scan. And like I said, not everybody needs that, but that comes after the StratX report usually.
After you complete all your testing and you're determined that the valves will benefit you, you would get scheduled for your procedure day. Again, it varies kind of where you get your valves done at, but the first step is always the anesthesia portion. We've already determined that we know you have end-stage lung disease, and I would say, 90% of my patients tell me, my doctor told me I could never have anesthesia because of my lung disease. Well, I'm telling you that's not always true. Yes, you shouldn't have anesthesia for 7 hours in a row or 5 hours in a row, but the procedure takes about 45 minutes. And, at our institution, we intubate patients and we give them general anesthesia for that 45 minutes. And we've never had any patient have any problems coming off of anesthesia after the procedure. Some places do it with just moderate sedation, which is that twilight sleep that you may have gotten during colonoscopies or something, but we're never going to do this procedure awake. And so you'll always have some sort of anesthesia for the procedure. Like we said in the beginning, the procedure is done through a bronchoscopy scope, and I put a picture here for you. This is what a bronchoscope looks like here at the bottom. And the whole procedure is done through this channel port right here. We put lots of tools, and the valves all go through this little channel port, goes all the way down the scope and pops out the end, and that's how the valves are deployed. It's all through that while you're asleep during the procedure. Some facilities do it through the mouth, some facilities do it through your nose, some facilities do it with a breathing tube called an endotracheal tube that hooks you to a ventilator. Again, it all varies in the way your physician's going to perform the procedure. But again, no cutting, no sutures, no nothing. It's all done through this scope. During the procedure, not only do we do an airway assessment of the procedure to make sure there's nothing abnormal about your airways, we clean out any secretions that you may have, and then we do this Chartis assessment. A Chartis assessment is really simulating the valves to the area of where we want to put the valves without actually placing them. We blow up a balloon in the area of the lung where we want to put the valves, as it measures the airflow from your lungs, and it actually shows if the valves will be successful. If the airflow declines all the way and gets to 0, we know the valves would benefit you. So then we go ahead and place valves. If it doesn't get all the way down to 0, then we know that there may be some communication with the other parts of your lung, and that the one-way check valve, Zephyr valve, wouldn't benefit you. And so we don't want to keep foreign bodies in you if it's not going to help you. And so we wouldn't place valves on you that day. This is a very few patient population, but it does happen. Once the Chartis assessment tells us that you would be a candidate for the valves, then we go ahead and measure and place the valves. On average, it takes about 4 valves per patient, but it can vary between 2 and 8. We go in with our scope, we place the valves into the lobe we want to reduce, and then as the patient breathes, or you breathe, air that's already trapped gets exhaled out, and then the valve closes so that when you breathe again, that the air doesn't get retrapped. And the overall, the lung will get smaller, so that pressure on the diaphragm that we talked about earlier is now not there, and your diaphragm can move more freely. The entire procedure takes about, again, like I said, about 45 minutes to an hour for completion. And at the end, this is what your valves will look like from the inside. These are the airways on the inside, and you can see the valves here opening and closing.
So what to expect after the procedure? So in some institutions, you'll go right from the OR to like a progressive care unit or a step down unit so that you can be monitored. At our institution, you will go to the ICU right from the OR. So you're going to stay for a minimum of 3 nights in the hospital. The main reason that you're staying in the hospital is because your doctors really want to monitor you closely for the potential side effects of the procedure. There are a few, and so we really need to, and the risk of those side effects is really greatest in the first couple of days. So that's why we make you stay for 3 days minimum. The most common side effect is a pneumothorax, and that is really just a tear in the lung that causes it to collapse. And that is on the same side as where they put the valves. And it happens a lot if that lobe that we put the valves in shrinks too fast and your lung doesn't have time, the other lobe on that side doesn't have time to expand slowly, so it causes that tear. It usually happens, the greatest risk is in the first 24 hours, and then the risk decreases almost to the pre-procedure point by the time that you're discharged. So within about 3 to 5 days, your risk of a pneumothorax is really about what it was before you had the procedure. So how we treat a pneumothorax, it's treated by putting a small tube in the chest. And what that does is it sucks out that air that's now in your chest wall. And it's a pretty easy procedure that can be done at your bedside. And it's done rather quickly. Other complications are a COPD exacerbation, bloody sputum, which can be normal because they're in your airways and they're messing around in there, pneumonia, and in very rare cases could be death. Once you get discharged from the hospital, they make sure that you're stable and you're holding your oxygen levels and everything before they discharge you. But you get home and you can return to your normal life, whatever you were doing before. You're going to continue your medications that you were on prior to the procedure. You're going to continue your oxygen the same as you were before the procedure, because oxygen is a drug and it's really important to keep your pulse ox up. So don't try and wean yourself off. You got to make sure that, you keep your oxygen levels up after the procedure. Some patients feel better almost immediately. Some people go home and within a couple of days are, increasing their exercise and they're doing all of the things that they haven't been able to do in years. Other people, it takes time. And that's okay. Sometimes it takes up to 3 to 9 months to have the full effects of the procedure. Once you get home, your best thing that you can do for yourself is to increase your activity, because honestly, the more you move, the better you're going to feel and the better results you're going to have. So whether that's just walking laps in your living room, or whether that's, going to pulmonary rehab, if you have one close by, or doing an online pulmonary rehab, super important that you get active and you stay active. And over 75% of patients have improvement in either lung function, the ability to exercise, or their quality of life. And really, that's what it's about. It's improving your quality of life and letting you do more of the things that you want to do. That's really our goal.
And with that, we'll take some questions. I'm looking at a few.
Thank you guys very much for that.
Yeah.
I think before we go to the Q&A, because we want to close the slide, so we have you on the full screen for that, can we just show that last slide that shows people where to get more info? There we go. So after we do the Q&A, if you still have more questions or you want to do some more research on your own, we encourage you to visit our mylungsmylife.com website, which has FAQ section, all of our videos. This video will be up there in a couple of days. And then if you want to speak with somebody, we actually have a Zephyr care team that can answer additional questions by phone if that works better for you. And the number for that is 833-654-COPD. So we can close the slides, I think, and dive into our questions. So I can moderate this and give you guys the questions, and you just let me know who's the best to answer. But one of the questions that we had was about follow-up after the procedure. Are patients going to have to come in for a lot of appointments? Do they go to the hospital? Do they go back to their pulmonologist? If you could talk a little bit about that, that would be great.
Sure. Okay. So once you're discharged from the hospital, you come back about 45 days after your procedure. When you come back, you're going to have, at least this is specific to our facility. I'm not sure what your treating facility will have, but our facilities, you come back 45 days after your procedure, you're going to have a chest x-ray, a complete pulmonary function test, and a 6-minute walk, and you're going to be seen in the clinic by either a doctor or nurse practitioners. They're going to really evaluate if you've had reduction of your lobe, the targeted lobe, and they're going to look at your gas trapping and seeing how much your gas trapping has improved, also to see how your exercise tolerance has improved or not improved on your 6-minute walk. So that's the 45 days. And then you come back again at 6 months and you do all that same testing again, except that we do a CAT scan at 6 months here. With the CAT scan, we evaluate if that lobe has deflated also. And we also look for valve placement. We look at, again, your pulmonary function testing and your 6-minute walk to evaluate if you've had improvement. And, usually at that time, we might talk about, if you're not having the expected improvement, then we might talk about a revision. And then again, you come back at 1 year post valve placement and we do all that same testing again, an x-ray if you're doing well, a CAT scan if you're not, and then we go from there. But after that 1 year, you don't have to come back to the treating facility. And in the meantime, for all your other pulmonary care, you go back to your primary pulmonologist. We are, just treating you with the valves. We're not taking over all of your pulmonary care. You want to stay with your regular pulmonologist to manage your oxygen, your inhalers, your nebulizers, and then, any other pulmonary needs. You want to really keep seeing your primary pulmonologist.
Perfect.
And the other thing I want to kind of add on to that is that the valves are like adding another inhaler to your regimen. It's not, I get the valves, now I can come off my prednisone or my steroids or whatever. We don't get rid of the COPD that's in the other parts of your lungs. This is really another additional treatment to what you're already receiving as your maximal therapy from your pulmonologist, as well as your oxygen. There's no guarantee that you will come off of your oxygen after getting the valves and having improvements. Has it happened? Yes, but it should not be an expectation with the procedure. It really is to improve that shortness of breath so you can be more active and do the things that you enjoy.
We have a question about hyperinflation, and someone is asking, does the patient's pre-procedure hyperinflation levels indicate how they'll do post-procedure? So if we could talk just a little bit about maybe start off for the whole group on reminder of what hyperinflation is and how that plays into this.
Of course. Hyperinflation, again, is that gas trapping in the lung, which leads to the lungs being longer than they should be for the body. And that's measured on your pulmonary function tests. Yes, the more gas trapping you have, the more, bang for your buck that you will get. The studies have shown that patients with gas trapping over 150% will benefit from some sort of lung volume reduction, whether it's surgical or with valves. And so that's really the number we're looking at. The previous trials only kind of studied patients with gas trapping over a specific 175%, but, we've we've treated over 200 patients at our institution, and we really do think we have really seen results and patients who've benefited from gas trapping in the lower range of 150. But yes, the more hyperinflation and the more gas trapping you have, the more relief, I guess, or more symptom you'll get for improvement. But yes, I guess is the answer.
That's perfect. We have a couple of questions that have come in around who is a candidate for this, and is there anyone who's definitely not a candidate as you're going through that evaluation process?
Yeah. I mean, gas trapping is key. It's those patients who are debilitated from shortness of breath because of gas trapping. Patients who have frequent COPD exacerbations that they need steroids and antibiotics for and get a lot of infections are not ideal candidates because the valves are a foreign body. And so if you have more bronchitis symptoms or infection symptoms, this may not be for you. You may not have gas trapping. You may be more plagued by bronchitis symptoms, but there are treatments out there for patients with bronchitis too. And so this wouldn't be the right procedure for you. It really is for patients who are short of breath because of gas trapping, and that's who would benefit.
Thank you. And you touched a little bit about this already, but a couple folks have asked questions, so I thought maybe we could revisit it. There is this risk of a pneumothorax, which is a tear in the lung, causing the lung to collapse or deflate quickly. Can you talk a little bit about how that is managed, being that it's known and you're prepared for it? And also, how do patients who experience that complication, do you see them tend to see benefit as patients who don't have that C?
So yes, pneumothorax is the largest risk to the procedure. And I don't really call it a complication. I just call it the nature of the procedure, let's say. So if we put valves in the left upper lobe and you get reduction of that lobe immediately, meaning that valves were successful right away instead of that slower 45-day period that we like to see. If let's say the lower lobe can't expand to fill its space in time, sometimes it can tear a little bit and that lower lobe will collapse. And when that happens, you're in the hospital and we're prepared for it. So at our institution or in other institutions I've talked to, there's carts or bags or suitcases at the bedside that have all the supplies to place a chest tube. Most chest tubes nowadays are called pigtail catheters, and they look kind of like this. They're really small, flexible, straw-like catheters. And what we do is we come to your bedside, we numb up the area of the chest, and we put the tube into you over it's like starting an IV, but it's a catheter. And then we just suture it in place and leave it there until the lung re-expands and it heals itself. That varies between patients. It can take anywhere from 24 hours to 7 to 14 days, but it all kind of depends on it. And every institution manages their pneumothoraxes differently. We don't send patients home with chest tubes. Most institutions don't. There is a handful of patients that can manage a chest tube at home. But I mean, it would something you would collaborate with your treating physician about. The risk is about 20% in the studies or 25% within the studies. Nationally in the United States, it can be anywhere from like 15% to like 30%. I mean, we're 17% at our institutions, but that doesn't mean we're not treating high-risk patients. It's just, again, it's the nature of the procedure and it is what it is, and we're happy to manage it. In perspective, if you were to get lung volume reduction with a surgeon who did cut you open and take your lobe out in the same fashion as we are simulating with valves, 100% of patients come out with a chest tube. 100% of them have a pneumo, and every single patient comes out with a chest tube. Ours is less, the valves are less risky. That's why it's considered minimally invasive and why it's available to more patients other than surgery.
Thank you. We have some patients asking about pulmonary rehab, and is it a requirement and why is it so important?
So at our institution, it used to be a requirement pre-COVID, but as everybody knows, all of the pulmonary rehab programs shut down during COVID, and then we're very slow to open back up. A lot of people have a hard time exercising with a mask on, which is usually still a requirement in the pulmonary rehab programs themselves. So at our institution, we no longer require pulmonary rehab, but we highly encourage it, or doing an online pulmonary rehab program, which there is one that is at pulmonarywellness.org. And there, it's a really great program. I have patients that do that exclusively, and I would definitely recommend doing something like that. If you have a treadmill at home, you should be walking back and forth in your house, even if the weather is bad. I can't stress enough how the more you move, the better you're going to do with the valves. That's the goal, is to make you more active, to have you have better quality of life, not to put the valves in and then you go home and take it easy, because then you're not going to get those results. You're not going to have that improvement in your quality of life if you just go home and, sit. So I tell people over and over again, get up, even if you're just walking laps in your living room. It really does make a difference, and it really will improve your outcome.
Pulmonary rehab has really been studied, to death, essentially. And it has shown to improve lung function a 5%. And so we do recommend it for anybody. There's online resources and chair yoga and online pulmonary rehab that you can do just from your living room.
Great, thank you. We have a couple questions about, does insurance cover this in the patients that you're treating? Are you seeing any insurance challenges?
So insurances are much better now than they were when we first started doing this procedure. I would have said, last year, Blue Cross Blue Shield was the bane of my existence, as they would definitely deny everybody at least once, if not multiple times, and we would have to appeal and appeal and appeal. Now that it's become the gold standard of treatment for COPD, we are having less and less issues with getting authorization. Medicare A and B does cover it at the 80%, just like they do everything else. And then the gold standard of extra, insurance would be like AARP. They cover everything. But, usually if we do have to appeal, it's rarely now. We don't go forward with scheduling your surgery until we have authorization, because you don't want that bill. And no, I don't want that bill. So, it's definitely something that it has become much easier now that this has become the gold standard treatment. And yeah.
Great news and great to hear. We have a couple of folks who are asking if when they come in for their testing, can it be done at one time, or how many appointments does the average patient come to as they're going through that evaluation process?
Okay, so that is real variable depending on where you're going. So it really depends on the treating facility you're going to. Some facilities make you come back multiple times and do, this test this day, this test this day. Some, you come and you have most of the testing done before you come for your consultation. And then, some you get it all done in one day. So it really kind of depends on the facility you're going to. Here, you're here for a couple hours, and whatever testing you need, we're going to have it done all back to back in one day. You're going to be exhausted when you leave, but you're only going to have to come here one time before your procedure if you're a good candidate. So, it's really important that a lot of places you have that pulmonary function test first to make sure that you are a good candidate and you do have that hyperinflation and gas trapping. And then everything else, is kind of like you can get a lot of stuff done locally at your primary pulmonologist or at a local hospital. But it really just depends on where you're going to have your evaluation.
Thank you. And I think we just have time for one more question, which is, do you one of the big benefits of minimally invasive and the fact that the valves can be taken out if they're not seeing benefit. Can you touch a little bit about patients who come in and are maybe saw benefit and aren't seeing as much anymore, and what you do to evaluate whether they need a valve adjustment or to remove the valves?
When I see those patients in clinic who maybe aren't doing as well, you can usually tell on their pulmonary we do this objective assessment with pulmonary function testing and that 6-minute walk distance. And if they're still crushing it on the breathing test, that they still have reduction on their test and on their images, but their walk distance is not as good, then I can tell it's because of debility or weakness, or maybe they had a hospitalization for something. And so we really do try to tease it out. Or maybe they have swelling in their legs and need, a cardiac assessment. So it really is just, going through everything and looking at the patient and assessing them to see really if it's the valves or not. If I suspect it's the valves, we always get a CAT scan to see if the valves are seated properly, if there's any leaking, has anything moved. If I'm still not sure, sometimes I'll bring them back for a bronchoscopy to look at the valves individually and see what's going on. Maybe they just need antibiotics for an exacerbation. So it's really just an individual assessment of the patient when they come in.
Well, thank you, Jill and Rebecca, so much. This was really informative. And we do have a bunch of questions we didn't get to. So I just want to let our attendees know that we will be getting you answers on those directly by email. And you can always reach out to us on our website. We have live chat that will be available as well after the webinar. And that's www.mylungsmylife.com.